Our next speaker, Dr. Nguyen from Vietnam. He'll be discussing his presentation entitled Progress in Prevention and Treatment of Spinal Cord Ischemia in TEVAR.
I am chairman and all of my friends in Thailand. It's an honor to me for me to be here, and thank again for the Dr. Boon and all of the Medtronic team to invite me here and meet a lot of friends in Thailand and some other country. And my presentation is about the prevention and treatment of the spinal cord. It's called me the SCI is the TEVAR. I am the cardiovascular interventionist. I come from the north of Vietnam. It's a university hospital. My hospital is a new gate and new building. You have to focus on the surgical activity, and maybe it's the oldest center of the cardiovascular and thoracic surgery in Vietnam. And I saw some case in my center. You have a male patient. He has a 76-year-old. He has history of tobacco abuse. There's a QMI with 2 stents and LAD and the second place. He had a CBD, he had the hypertension and the hyperlipid edema. You complain about the chest pain and the abdominal. And we saw the stent and LED and the circumflex is the pattern and multi-slide CT. We also hold aorta is the aneurysm of the aortic act and descending aorta and the big AAA. And this is the whole CT view shows that you had the problem inside the aortic act aneurysm, and you had the descending aorta. We had the big aneurysm in the AAA, and this is my in my center is not available from the produce from the Inno or brand or TEVAR or for the brand stent graft. That's why you choose the hybrid produce in the. We had the infrared AAA replacement and the bypass for 2 conduits from the SMA to celiac and the both renal artery. After that, you put the TEVAR maybe cover on the zone 2 and LSA revascularization by the institute needle and with the CSF drain catheter before produce. I put the CSF drain before for this patient in Vietnam. You don't have the Medtronic equipment for the follow up to the CSF. That's why I use for the some equipment some different from the anesthesia and before the produce. And this in the operation, we have the big AAA with the operation to replacement AAA, and after that they put the 2 conduits from to the go to bypass from all the SMA, celiac, and the both renal artery, and I transfer the patient go to the from to the cath lab to check angio, the pattern of the AAA, the pattern of the 2 conduits, and I put the stent graft from TEVAR from Medtronic to cover to the SLA, and after the cover on the TEVAR, I tried to the LSA revascularization. You had the 5 steps. Step 1, you check the angio, so all rings of the LSA. Pass 2, I put the puncture by needle device, and I put the guide wire all the way. I use the V18 go through from the whole penetration, and dilate with the balloon with the 3 meter and dilate with the 5 meter, and put the stent from the penetration for the LSA. This is my result. You can see the pattern of the LA, the stent TEVAR cover on from to the zone 2 go to the abdominal, and the pattern of the 2 conduits from the celiac and LMA and and this patient will hold a paralyzed and discharged from my hospital after 1 week. And you can check a lot of review some a lot of the report about to the transient SCI in some patient, maybe around more than 2.2% until 5.7%, and on most of the case you see that incident of the TEVAR may be less than more than operation. That's why you see that significant maybe on 1.4 or 3.4, but always is some problem when you try to cover all of the aorta body. A lot of the machine of the SCI and the TEVAR, you cannot supply enough, you cannot cover all of the intercostal artery, or sometimes you had to not enough supply for the collateral after you put the stent, or some maybe you had to ischemic from the in produce with some doctor when you multiple mission of the why we lead visceral embolization. And we try to know about the anatomy of the spinal cord arteria supply. We have the four level: the subclavicle, intercostal, the lumbar artery, and the hypogastric artery. When we try not to preserve all of the four level of supply, and when you have to more cover more than one level of supply, you try put the SAF rank and prevent the SCI after the TEVAR. I had a lot of big factor for the SCI. We had the length covering the aorta, we had the Crawford type 1 or type 3 aortic involvement, we had the previous aortic surgery, or you occlude more than one level of the artery supply, especially in the absolute of the LSA or the hypogastric artery. And the post-operation hypotension or the high cerebral spider maybe more than 10, and the patient had renal failure. And you had a lot of the strategy to prevent spinal cord ischemia. You had the spinal cord plus the drain. You had to avoid the hypertension. You had the hypothermia. You had the strategy. You had maybe you divide the body inside the one state or two state. You had the LSA revascularization, or you have the permission of endolic to try to more supply about for the collateral, or the peri-operation use neural monitoring. And in my center, you try to prevent the spinal cord. You had to some step in my artery produce. The first, I try to image of the artery aortic and the spinal artery supply. And second, in the case of supply artery cover, I always try routine revascularization, maybe or bypass transplantation, or stent graft with the side branch, or maybe the fenestration. In case of the bilateral hypogastric occlusion, maybe use a hybrid or use a distal branch stent graft to try to the revascular from the hypogastric, and early remove of all the iliac artery flow blocking the sheet. Maybe you change from to the biggest sheet go to the smaller sheet. That's why more supply of blood for the iliac. And stress standing, maybe you delay or one state or two state, maybe help to the to supply to the collateral for the spinal. And maybe you had the coil embolization before the stent graft to maybe to induce the collateral artery development. And if you had to the medical precaution, maybe you had a cerebral spinal drain. Sometime in my hospital, all the way, I put it the day before or on the day endovascular produce to enable hypertension and without the risk of the epidural hematome. And always stay in the ICU follow up to 48 hours. And post-operation, I keep the mean arterial pressure more than maybe 80, and to prevent spinal cord hyperposition. And when you put the spinal cord brush, I always control the pressure on less than 10, and all the way neurologist monitoring, maybe it unlit the 48 hour. And if you had the CSF drain, maybe pressure on less than 10, and all the way output not than more than 10 milliliters per hour. And systolic artery pressure the same. Maybe gives more the mean artery pressure maybe more than 100. And you had the some drug is the dexamethasone and mannitol, or sometimes if the patient you have operation, you try to reduce the hypothermia. And you had the two problems at the SLA revascularization and the SCI branch. And SLA vascularization, a lot of the guideline to suggest all the way to routine to perioperative for the SLA. In my hospital, it's a time now. almost okay, selective or emergency or emergency. I all the way to try to the revascular RSA, maybe by surgical hybrid or sometimes the penetration. You had a high risk patient. You had to need the revascularization. Either you will cover or not as a patient almost as a long segment, and has this patient you have the previous in the AAA or sometimes aortic antivision in history. A lot of way you can to do the hybrid body is the my hospital. You can do the hybrid. This problem is this patient in the picture you had a last vertebral, and that's why I choose the transfer from patient the vertebral go to the LSA and put the left carotid and put the stent. And you can use the chimney technique. And I talked a little about the penetration. Penetration is usually in my center in my hospital. I use the in vitro, you use the on-table penetration. On sometimes you use the institute by a needle. Institute laser I had to 5K, but I try to follow up the long term, and I don't talk in here. This is my case on the table to penetration. You can see use the lighter and put the stent to cover to the marker with the hole, and put the stent, retrieve the stent inside the long seat and put inside the people. This is my case. Sometimes when I don't put the stent, but if the check the supply from and the blood flow from the RSA is not good, maybe I try to put the stent, maybe bare metal stent. In some patient I put the cover stent. If you try don't embolic form to the penetration every day come to the descending aorta. And the institute needle penetration this is derived from the full through from the Litech company. The first time the license of my case in the first I try check all the way check the origin the exact way. I put the device, I inflate the balloon, and I take the puncture. After take a puncture, you can pull the V18Y and dilate with the balloon, maybe a smaller than the bigger, and I put the stent inside. If you do the in situ needle penetration all the way, I put the stent because you know that the whole penetration by in situ by needle is very different when you take a hole when you're on table. And this is some of my result. You had the 14K today, and I hope to increase the number in the future. This is my something different in cerebral spinal drawing in my center because I don't have the Medtronic device. That's why I use anesthesia, and the same way. To have indication for the drawing is the TEVAR, the same when you high risk patient, when you more cover, when you had the convention collateral, and you had some patient you had treatment by we had the patient after TEVAR, we had the symptomatic spinal ischemia. And the same is I insert the spinal puncture is the epidural equipment by the number L4 or L3 number all the way by to anesthesia, and sometimes it's anesthetist it don't want to do it, maybe I do it, and CFA pressure is normal, confirm maybe prefer more than less than the 10, and no more than the 10 millimeter should be drained and remove after the 24 and 48 hours after its placement. Before removing, drain it keep closer and to check that no clinical symptom. And high risk in when we put the CFF drain is infection or spinal heterotomia. And conclusion is incident FCI maybe 2.2%, maybe 5.7%. When you prevention, we had the perioperative prevention of collateral flow, LSA or hypogastric, and say catheter and ICU monitoring in the high risk patient and treatment by CF drain and maybe the some methods you can use depend on the ICU. And thank for your attention.
Thank you, Dr. Nguyen, for that very extensive discussion on prevention of spinal cord injury.